Yeah, thank you very much. Again, a true pleasure to be joining all of you this evening. But let me just get into the plan for at least my portion of the meeting, where we have a list of essentially six different studies to discuss with you. And the number of slides actually diminishes from top to bottom. So the most slides in the first one, then fewer and fewer and fewer and fewer. And depending on the time allotment, we may summarize the last two studies in a very quick fashion. So let's get going, because they all have impact to clinical practice. Very interesting data applicable to clinical practice. Next slide. Before we go to the Destiny Breast 04, which was the trial for patients with HER2-low breast cancer, we thought about putting a couple of slides related to the setup for Destiny Breast 04, which was the Destiny Breast 03 trial, which was the trial comparing trastuzumab deruxtecan versus TDM1 in patients with refractory HER2-positive metastatic breast cancer, which led to the FDA approval of trastuzumab deruxtecan just a couple of months ago by the FDA for patients who had received one prior regimen in the metastatic setting, or patients who had developed disease recurrence within 6 months of completing adjuvant therapy. This was a very important approval. Obviously, this approval was based on the impressive data that had been discussed at our meeting before, which still is maintained, showing the massive improvement in progression-free survival with trastuzumab deruxtecan versus TDM1. And we're not going to go over the details of that study, well known to you guys. But the main issue is that since our previous meeting, not only has the FDA approval occurred, number two, the NCCN guidelines highlighted HER2 as in the preferred category 1 treatment in the second-line setting for HER2-positive breast cancer. But again, it's important to realize that utilization within 6 months of neoadjuvant or adjuvant therapy is also allowed. And at ASCO, on the next slide, we have just one slide of a long-term safety data from that Destiny Breast 03 study highlighted here. And this was shown at ASCO. So I'm just going to mention a very few points on this one, which is, we need to remember the nausea in the setting of the use of trastuzumab deruxtecan with grade 3 observed in this study, or greater, about 6.6%, a little bit of anemia, a little bit of alopecia. And then but the other issue I wanted to highlight is the timing of the first onset to the development of ILD. In this particular study, there were no grade 4 or 5 ILDs, but there were, and there was only a rate of 0.8% of grade 3. And grade 3 obviously requires oxygen therapy for patients. But, again, for our practice, it's an issue of thinking, what is the time to onset of the development of ILD? And in this study, it was 181 days, ranging from 33 to 507. Another point to highlight here is that the median duration of treatment with trastuzumab deruxtecan was approximately 15 months. So again, it's long-term use of this antibody drug conjugate. Next slide. Let's get then to the Destiny Breast 04, which addresses the use of trastuzumab deruxtecan versus single-agent chemotherapy in patients with previously treated HER2-low metastatic breast cancer. Next slide. So to set up the stage for this particular discussion, I thought it would be really nice to share this schema with you in terms of how do we define HER2-low. And on the left side, we have the current classification and treatment that we've utilized to manage patients with breast cancer based on HER2 testing. So the traditional definition of HER2 positivity is highlighted on the dark blue, has been patients whose tumors are either IHC3+ for the protein or ISH, or gene amplification by not only the ISH technology, but also next generation gene sequencing. But essentially, Daiichi Sankyo has created a new definition of HER2 positive breast cancer. They defined that as IHC3+ or IHC2+ with ISH positive disease. Certainly, we have had traditionally the categories of what used to be considered to be HER2 negative, which were the HER2 negative hormone receptor positive. And these patients, of course, received endocrine therapy and CDK4/6 inhibitors, and of course, PARP inhibitors based on BRCA1, BRCA2 mutations. But amongst the HER2 negative disease, we had the so-called triple negative breast cancer, which obviously have been treated with the agents listed here, including sacituzumab govitecan. But based on the newer data that were discussed at ASCO, I think it's time to reclassify the definition of HER2 in the setting of breast cancer. And the definition, again, that Daiichi Sankyo has outlined, HER2 positivity, it's interesting, but for HER2 low, what they used for their trial was IHC 1+ or 2+ with negative-ish. And in their trial, those were, again, the patients enrolled, and they still had a category of HER2 negative, which included patients with IHC 0. And these patients were not enrolled in the Destiny-04 trial. But to me, this is another area that will continue to be further evaluated with the use of trastuzumab deruxtecan. On the new, if we think of the new classification after Destiny Breast 04, we're still missing a group of patients, in my view, which are the patients whose tumors are IHC 0 or 1, but ISH positive, because at least based by classic definition, these patients would be considered to be HER2 positive, although that they're not included in the HER2 positive definition by Daiichi Sankyo. Next slide. Let's go over the study, super high level on the next, starting on the next slide. Here we have the study design, and there's some things to highlight on this slide. Number one, the HER2 low included the patients with tumors that were IHC, maybe the previous slide, IHC 1+ or again, or IHC 2+ ISH negative, 1 to 2 prior lines of chemotherapy. If endocrine therapy had to be used, if the tumor had hormone receptor positivity, and there was appropriate stratification as listed on this slide. Randomization was 2-to-1 to trastuzumab deruxtecan versus single agent chemotherapy by physician's choice. An interesting aspect of this study is that there were about 480 patients enrolled whose tumors were HER2 low but hormone receptor positive, and there were 60 patients who were so-called HER2 low, hormone receptor negative, which in the past, they would have been classified as TNBC. Next, and the primary endpoint of this study was progression-free survival by a blinded independent review in the patients with hormone receptor positive disease. Next. We're gonna go over the data like extremely fast because you've heard a lot of high-level discussions about this, and I'm just highlighting a few points. Number one, there was pretty much pretty good distribution of both subtypes of HER2 low, 1+ or 2+ IHC negative. And in terms of hormone receptor status, I already alluded to this, but the majority of patients had hormone receptor positive disease, with about 58 patients or so who had hormone receptor negative disease. There were patients with stable brain metastasis, and otherwise the patients had visceral metastasis. Next. Great. In terms of prior lines of therapy, this information is listed on this slide for the different subsets of patients, hormone receptor positive or all of the patients. And the main point to highlight here, if we look at the hormone receptor positive patients, is that the patients that had essentially the majority 1 prior line of chemotherapy, but a significant number of patients that had 2 prior chemotherapies. And in terms of the use of CDK4/6 inhibitors, about 2/3 of the patients had received CDK4/6 inhibitor based on their hormone receptor positivity. So this is a group of patients with refractory hormone receptor positive disease. Next. We started then looking at the results of the study in terms of the primary endpoint, which was progression-free survival in patients with hormone receptor positive disease. And the data are so consistent in all subgroups analyzed. But in the primary endpoint, the hazard ratio was 0.51. And I believe, and you probably all agree with me, that when we look at studies, it's more, in my view, to look at hazard ratios. It's actually to look at the absolute differences. And in this study, there was an absolute improvement in progression-free survival in hormone receptor positive population, HER2 low, of almost 5 months, as demonstrated on the left graph. And if we took the data from all of the patients, the numbers were pretty consistent, again, with not only statistically significant, but certainly clinically significant improvement in progression-free survival by using trastuzumab deruxtecan in HER2-low population compared to single-agent chemotherapy. Next. We're gonna go for the person who's moving the slides let's go pretty fast on the next few slides. Essentially, overall survival, clear improvement without any question, absolute improvement of more than 6 months with the use of trastuzumab deruxtecan. Another aspect, though, that I would like you to remember for future is that the median overall survival is 2 years versus the median overall survival being about 1.5 years. So obviously major improvement for patients, but there remains work to be done. We're not curing every patient, although the data are notable, showing the improvement compared to chemotherapy. Next. So here I have the data for the patients who were now the traditional patients with TNBC, essentially patients whose tumors were lower than HER2 IHC3 plus. The tumor was also a hormone receptor negative, both from estrogen and progesterone receptors. So this is the group now that is the true triple negative disease. My gosh, and look at the data. I mean, really impressive improvement in progression-free survival with a hazard ratio of 0.46. And also look at the overall survival, again, for these patients with traditional triple negative breast cancer, where the median overall survival went from 8.3 months to 18.2 months. Of course, this was based on a small number of patients, 58. But in my view, this data challenged previous approaches for so-called TNBC. In other words, the new TNBCs will be a smaller percentage of the total population of patients with breast cancer. So what is that number? Well, traditionally, TNBC has accounted for approximately 15% of all breast cancers. And I think now TNBC, in the purest way, will be essentially about, it will be about 6 to 5% of all breast cancers, which then will essentially limit the utilization of agents solely approved for triple negative breast cancer, such as sacituzumab govitecan. Next. Certainly, the data are very consistent, also related to response rate. I mean, and these numbers are dramatic, with a response rate of, as you see over there, of 53% versus 16%. In the hormone receptor positive, in the hormone receptor negative, 50% versus 17%. Clear. Next. Great. And then safety is, as we expected, really no new signals, with the median treatment duration demonstrated on the right side of trastuzumab deruxtecan of 8.2 months versus TPC, treatment of physician's choice of 3.5 months. So again, even with the longer duration of therapy, the side effect profile was as expected. There was still the incidence of ILD pneumonitis in 8.2% of the cases who received trastuzumab deruxtecan. And if you look in this particular study, there were a few patients who had safety associated mortality. So this is an issue that I think, the more I learn about this compound, it appears that the rate of pneumonitis continues to decrease as studies continue to be done, but it's still an issue that we need to pay attention to for our patients. And again, following the guidelines that have been outlined, it's the completely right approach in this particular scenario. Yes. Yeah. There's a question that was raised before I move, which is a new definition of very low HER2. I think this is made up by Daiichi Sankyo. So I don't really know what that means. So I am not ready to include that right now in a definition of HER2 status, but I'm prepared to have the definition of HER2 positive, HER2 low, and HER2 negative. But understanding that even IHC 0 cases do have HER2 protein on the membrane, but this very, very low HER2, we'll see if it catches on. But again, it was invented by Daiichi Sankyo. Next. Side effects, really nothing new to discuss. Again, mentioning the nausea in 73% of patients. So now in the package insert, you know that antiemetics are recommended, which had not been recommended when the study was initiated, or even with the different studies with this compound. Just something to pay attention to. and as well as the alopecia. And this is another issue that has come up in discussions because alopecia was noted in 38% of the patients. And that's still a tough side effect for our patients with advanced breast cancer. Next. ILD, critical issue, and I alluded to the fact that there were a few deaths associated with ILD 3, a total of 0.8%, only 1.3% rate of grade 3, still notable, no issues with cardiac toxicity. Next. So, trastuzumab deruxtecan is the first anti-HER2 therapy shown to demonstrate benefit in patients with HER2-low breast cancer, with doubling essentially of the PFS and with a significant improvement also in overall survival. The benefit was seen in the different subgroups analyzed: hormone receptor positive, hormone receptor negative, IHC1 plus, IHC2 plus, each negative. So this is a study that it's a standard of care change that has also been highlighted now by a change in the NCCN guidelines. Next slide. And this is what's demonstrated on this slide. So NCCN was very fast. They didn't wait until an FDA endorsement, but the trastuzumab deruxtecan has been now included as category 1. Unfortunately, what NCCN did is that they put that in the HER2 negative category, which I think is going to create some confusion. In my view, they should have actually acknowledged a HER2 low population. But at the same time, I realized that they decided to still put that in HER2 negative because the HER2 low scenario would be applicable to the use of other agents too. But it would have been nice, people are looking for this, they may have difficulty finding it because there's not a HER2 low category within the NCCN guidelines. Okay, next. So, I think the new classification is appropriate, but at the same time, this deals with the importance of all of us in practice to talk to our pathologists, because sometimes there can be variability in concordance of IHC readouts amongst pathologists. Maybe for the slides to be reviewed by a couple of pathologists to be sure that we identify the patients who may benefit from this new therapy, as well as the thinking that there's a lot of work ongoing to determine whether there could be other technologies such as messenger RNA to identify patients who may have HER2 low expression in their tumors that could theoretically be eligible for this innovative treatment. Next. That was Destiny-04. So I took half of my time to discuss this study. And for the rest of the studies, let's just move on because I have fewer slides for the others. But again, they were really important studies for practice. And one of them was the test of whether sacituzumab govitecan, which clearly has been approved for patients with triple negative breast cancer, could have a role in patients with non-triple negative breast cancer. In other words, patients with hormone receptor positive, HER2 negative metastatic breast cancer. Next slide. So the randomization was actually quite similar to the randomization that was done in Destiny-04, except that this was a one-to-one randomization in patients with 2 prior lines of chemotherapy for metastatic disease or recurrent disease within 1 year of neoadjuvant therapy, and that was required. If, in other words, that counted as one chemotherapy, and it was a one randomization against sacituzumab govitecan versus single agent chemotherapy. On the primary endpoint was progression-free survival. Next slide. And here we have the distribution of prior therapies for the patients, and the bottom line is that everybody had received prior chemotherapy, and all of the patients essentially had received the CDK4/6 inhibitor. So that please, next slide. Let's go over the next slide. Shows the result of this study in terms of progression-free survival. And it was a very interesting set of data because the bottom line is that the median progression-free survival, which is outlined on the right side of the graph, shows a median progression-free survival of 5.5 months with sacituzumab govitecan versus 4 months with physician's choice, has a ratio 0.66. But to me, the issue is that the difference in progression-free survival median was a month and a half. Just really, not a very big difference in absolute terms in progression-free survival. At the presentation at ASCO, there was a lot of discussion about what's happening at 12 months, the separation of the curves at 12 months, but still the PFS only 21% at 12 months versus 7.1%. They're really stark numbers for me. Again, we're talking about the hormone receptor positive population. Next slide. So we have also the overall survival data, and the number of events still rather small, but essentially no hint right now of improvement in survival with sacituzumab govitecan versus physician's choice. Again, in the refractory group of patients with hormone receptor positive disease, you see the hazard ratio still at 0.84. Next slide. So on the next slide, I have what I consider to be important also to look at the median duration of response in this study, 7.4 months for sacituzumab govitecan versus 5.6 with systemic chemotherapy. A little bit better, but I think by saying a little bit better summarizes the data. Next slide. Agree. Yeah. So in terms of side effects, I won't dwell on this. You well know the side effect profile of sacituzumab govitecan, mainly the issue of diarrhea, grade 3 or more in essentially 9% of the cases. Next slide. So on the next slide, I really have, starting to think about the summary from this so-called TROPiCS-02 trial. Sacituzumab govitecan did provide statistically significant improvement in PFS over single-agent chemotherapy in patients who had received prior chemotherapy, prior endocrine therapy, prior CDK4/6 inhibitors, but the absolute improvement was modest. So this is one of the statistically significant studies with a clinical significance that is in question in the setting of some toxicity. So this study was, I'm gonna have to call it a positive study, but it's positive from the statistical standpoint. So I'm not really sure, and I would love to hear from you guys how you think you may or may not incorporate sacituzumab govitecan in the treatment paradigm for patients with hormone receptor positive HER2 negative disease, particularly if some of these patients now belong to the HER2 low category that was included in the DESTINY-Breast04 trial. But on the next slide, what we're doing is, I think on the next slide, we put a little bit of summary of what I've said already. So let's go right to the next slide, which actually, it's going to be a really nice slide for you to have for your review in more detail. But we have a side-by-side cross-study comparison with the NCCN endorsement of the different approaches for DESTINY-04, Breast04. We already have the HER2 low endorsement. For TROPiCS-02, we don't have any mention in NCCN related to their approach to the use of sacituzumab govitecan for patients with hormone receptor positive disease. I have the differences in PFS on DESTINY-Breast04, 10 months versus 5.4. If we look at the TROPiCS-02, 5.5 months versus 4. So it's actually really interesting to look at the PFS in DESTINY-Breast04, although that had hormone receptor positive and negative, 5.4 months, and then the median PFS for sacituzumab govitecan in TROPiCS-02, 5.4 months. Just fascinating to do cross-study comparisons, but look at the differences in median overall survival as well as median duration of response. So again, I'm not going to make too much out of a cross-study comparison, but again, we thought it would be helpful for you to have those data side by side. Next. So, taking all of this into consideration, discussing this DESTINY-Breast03, DESTINY-Breast04, TROPiCS-02, I think there is a consensus here that we're going to have a new definition of TNBC. We're going to have a new definition of HER2 status of primary breast cancer. For now, we're going to use immunohistochemistry and ISH. We're going to have to think about potentially improved ways or more sensitive ways to potentially identify other patients who may be classified ultimately as HER2 low. and thus potentially eligible for anti-HER2 therapy. Although you should know that there are already ongoing trials being conducted with trastuzumab deruxtecan in the setting of the IHC0 population. Great.
Edith,
yeah, go
do
ahead.
you mind to jump in? I mean, I think you're getting to a great point when we apply this to the community. It's a great problem to have, right? It's forcing a conversation, but it's a new conversation.
Yeah.
And for busy practices and just a lot that happens in the community, I'll ask this. You can obviously provide commentary or reshape my question just for Sujith and Eric. I mean, it's obviously positive, but how do you apply that change to your practice? And how do you start that conversation? Is it starting now? Are you waiting for more information? What does that look like? Because we know the community is always on the forefront where you're handed this NCN, but it doesn't really apply to how you operationalize something like this. And it's a mindset shift, right?
Yeah, absolutely. And I'm glad you brought up this question and the involvement of the pathologists, because in many places, the guidelines have been the pathologists should put specifically what the findings were, IHC 0, 1+, 2+. But essentially, in some places, what got to the oncologist was IHC, HER2 negative. And now that HER2 negative is not enough for decision making, and we have to make that change today. If the only information available on that patient is that the tumor is HER2 negative, there needs to be now probing with the pathologist to further define what the meaning of HER2 negative for that particular patient, to go back and say, is it IHC 0, 1, or 2+? Yeah.
Yeah, Joe, I would completely agree. We've actually had that discussion with our pathology group, because they need to know what we're looking for. While they're up to date with a lot of what they do, they might not read the newest DESTINY-Breast04 trial and know that we need now to define HER2 low.
Yeah.
And the other thing that we're beginning to do is even the HER2 zeros, we're checking them for ISH.
Yep, absolutely.
So I think that's an important conversation too. So not just redefining IHC, but determining who also gets ISH.
Yeah. Because
that's going to be important in determining who can get what appropriate trial. And someone had asked during the Q&A, and we'll jump in right now since we're kind of talking about it. What is a new definition of triple negative breast cancer going to be? Is it IHC 0, ISH 0?
Yeah.
I mean, that's what I assume it's going to be, but I guess we have to wait till that's further defined. But that's what I'm going to determine it to be.
Exactly. I completely agree with you. I think it's going to take ASCO time and ANCAP to gather the team and make and change the official guidelines. But I think the data are really so solid that we don't need to wait for the big changes to occur from the guideline standpoint.
But in Edith, I think for today's world, you still need to have some discrete guidelines in deciding who to treat and not, because ASCO and CAP could take a year before they come out with their own guidelines. I mean, it took us 20 years to figure out who is ER positive and PR negative, right?
Oh, and now they're reversing that definition, as you clearly know.
I know. So that's the issue. So I think for the working man, like Joel said, what does the working man do? I think we try to find everybody who's positive and make sure that the patients get the benefit.
I love it. That's
great.
Yeah, I'm glad this came up. Okay, great. Okay, I have 2 minutes to the others. So let's just be super high level, huh? Because I want to have time for questions. This was a small study, but we thought it was a great thing to just super highlight this to you. And again, the main issue that has been raised in our own meetings, with all of you, has been, what do you do if a patient has received the CDK4/6 inhibitor? Should you move that patient next to receive chemotherapy, or should you move that patient to potentially get an alternative CDK4/6 inhibitor? So this is really what was done in this particular study. It's called the MAINTAIN study. Let's just go to the next slide pretty quickly. And so the idea here was, again, a progression to endocrine therapy in a CDK4/6 inhibitor, and then for the patients then to be treated to changing the endocrine therapy or changing the endocrine therapy in combination with a different, the clock is telling me that I better finish talking here. The 30 minutes are up. So again, to add a new CDK4/6 inhibitor to the switch of endocrine therapy. Next slide. Let's go. Most of the patients had received prior palbociclib. Next slide. And here's just the meat of this study. Look at that hazard ratio in terms of progression-free survival. In blue, the line in blue for the patients who received the new endocrine therapy in combination with ribociclib. In the red, the line for the patients who had the switch of endocrine therapy, but without the CDK4/6 inhibitor. So again, the numbers are really fascinating to me. Look at the response rate, placebo 11% versus 20% if ribociclib was utilized. Look at the clinical benefit rate, 25% versus 43%. Next slide. So I think, the summary that I have from this slide is that this was a small but very interesting study, as it showed that switching to ribociclib and endocrine therapy after progression provided statistically significant improvement in PFS compared to not using a CDK4/6 inhibitor. And there were also the clearly demonstrated improvements on clinical benefit that included, and the benefit was seen in patients even who had the ESR1 mutation, wild type or not. So again, small, but I think we should pay attention to this study. Certainly sequencing obviously will take more work, but in practice, this is something I would consider in a patient who's already had, a CDK4/6 inhibitor to move to a second one. And, in this study was to start ribociclib. It may be that the same would occur to other agents, but I just wanted to share this data with you this evening. Next. The other study is the ABCSG18. And again, this is clearly a study that impacts clinical practice. Next slide. And the question here is the use of adjuvant denosumab. And the reason to include this is because at ASCO, the update was whether using denosumab a couple times a year reduced fracture, but also there were some updated data about progression-free survival and overall survival in the postmenopausal group of patients with hormone receptor positive breast cancer. Next slide. So here's the randomization: postmenopausal women, early stage. The patients really received the adjuvant non-steroidal aromatase inhibitor. So this was before the era of abemaciclib. Large study, 3,420 patients randomized 1:1 to denosumab once every 6 months or placebo, with the primary endpoint being time to first clinical fracture. Next slide, please. So here we have the data of the primary endpoint, time to first clinical fracture. Obviously, much higher for the patients who did not receive denosumab. The risk of fracture in red is the one for denosumab with a highly statistical result and also clinically meaningful. Next slide. But to me, the main issue here to discuss with you tonight is that in addition to the prevention of fracture, it is clear that denosumab improved disease-free survival versus placebo with a hazard ratio here of 0.83 and an absolute 9-year disease-free survival difference of 3.5%. There was also an improvement of bone metastasis-free survival. And there was also a really interesting analysis of overall survival, with the overall survival improving by 20% in the uncensored analysis, 26% with censoring that they did. And that was statistically significant. Again, on the next slide, you realize why I thought it would be worth to spend a few moments on this study, because it's important for our practice. And so now there are many new changes that have occurred in the use of adjuvant therapy for postmenopausal women. Before we were using endocrine therapies, now we have endocrine therapy and the use of abemaciclib, depending on the disease risk, according to the approval of the FDA. But we also have to remember the use of denosumab if there are no contraindications to this agent. Next slide. Essentially, every 6 months, again, denosumab should be considered. Quality of life was good. Next slide. So essentially, Paloma 2, let's go to the slide. We've talked about Paloma 1 before, and this was just a bigger study than Paloma 1. So it was a repeat, essentially, with more patients to determine whether letrozole improved the outcome in patients who received, if palbociclib, improved the benefit to letrozole. in patients with hormone receptor positive HER2 negative breast cancer, and this was the overall survival analysis using the design, palbociclib, letrozole versus placebo letrozole. Next slide. And what we see for the results of this study included the overall survival data, which was the primary endpoint of the study. And you look in the first row over there, the planned intent to treat analysis for overall survival, 54 months versus 51 months. That was hazard ratio of 0.95. So very clear, no improvement in overall survival. Next slide. There was a delay of the time to chemotherapy. So essentially what this study showed is that palbociclib in this setting did not improve overall survival. It did improve, we have the data with progression-free survival. But again, I thought it would be helpful to, again, put this in the context of the data that we've discussed with abemaciclib improving overall survival in this patient population. Again, we've gone over this before. There may be some differences in patient population, but it's nice to sum that up. Next slide. I already discussed that. It would be nice to have head-to-head comparisons of the CDK4/6 inhibitors. It's not likely that will occur. Yeah, that's great. And then the Lumina study essentially is a study looking at radiation therapy in the adjuvant setting in patients with what they consider to be very low risk breast cancer. And the way this was listed was in T1 and 0 luminal A. And I just want to let you know that, there has been a migration to use this term luminal in patients with hormone receptor positive breast cancer. And we just have to be very careful because luminal is really defined by PAM50. And if we don't do PAM50, we shouldn't be calling these tumors luminal. We should be calling them just hormone receptor positive. I had a meeting with Alex Pratt just last week, and we talked about this issue. But again, it has become almost so common to say, oh, yeah, luminal. But if we don't do PAM50, we don't really know if they are luminal. I just want to mention that as a side editorial comment. Next. So essentially, the idea here, what they did is that they enrolled patients with very small breast cancers, less than 2 centimeters, hormone receptor positive. Particularly progesterone had to be more than 20% positive. And they did central KS67, and they defined KS67 of less than 13 or less as low enough for the patients to be enrolled in the trial. And if the patients had a KS67 of greater than 13, the patients didn't participate in the study. So what they did is that if the patients had very low size breast cancers, high levels of progesterone receptors, and they had a central K67 that was low, then the patients were followed with a radiation therapy. Next slide. And then they looked at the incidence of events. Next slide. Oh, you have the demographic information. Let's go to the next slide. And essentially what you see is that the number of events was really small at 5 years. Local recurrence, essentially 2.3%, contralateral breast cancer, which shouldn't have been affected, 1.9%. Next slide. So the conclusions of this study were that for women older than 55, if the tumor is small, low grade, that you may consider obviating radiation therapy. And that's also listed on the next slide. And this was similar to many other studies that have been done in this setting. I just don't know how well this really translates into clinical practice because of the concern of the patients. But at least I wanted to share the data. So that's it for my slides. I've gone over my time allotment. But I hope the information has been helpful to your practices, and look forward to the cases and the education from my colleagues.
Edith, we never put a buzzer on you. Nobody puts baby in a corner. So you can take as much time as you want. In fact, I probably would say, Eric, I know you and Sue just have been looking at the questions. Are there anything in particular, I know you were sourcing them, Eric, that you think would be good to introduce to Edith right now?
I think one question, which is a theme that I've seen in the questions, is all the 3 CDK inhibitors seem to have a similar PFS in terms of hazard ratio, but 2 of them have survival benefits. Ribociclib in 3 studies now, abemaciclib in that study, whereas the palbociclib has now 2 studies with no overall survival benefit. So why is there a PFS benefit and no overall survival benefit? What's your rationale?
Come on, I don't know. I don't
Okay.
know.
That's what I think that's the right answer. So that's the,
No,
I think
no,
several
actually,
questions.
there's some very interesting data that are being developed amongst these agencies where there are differences in T cell activation, actually.
Okay.
And it may be a matter of immunological memory, even though obviously that has been a tough a part of the science in the setting of hormone receptor positive disease. But this is something that may be providing us with clues and will be worthwhile to study some more.
Okay.
So Edith, I'm glad you brought up the supportive care trial with Prolia, because I think so many of us focus on cytotoxic agents or CD4/6 inhibitors, but it's good to see what we used to call a supportive care measure have OS. And someone had a good question. Is this going to be used for, you think, in all early stage patients, or is there any early stage patient you want it in, or would you just use it mainly in the high risk patients? What is your thought?
Yeah, I would use it in practically anybody I'm deciding that they need to get adjuvant therapy. Really, breast cancer is so treacherous, and what we consider to be low grade, really, or low risk, would be a patient with extremely small breast cancer. But as you know, the challenge with this disease is that hormone receptor positive, they keep developing relapse for the next 20 years. Yeah, and at least, for the initial few years, I think this will be a good approach to take in practically any patient who also have a contraindication, because it also helps to decrease the fracture rate, even if it didn't improve OS and PFS, and it has been clearly demonstrated.